So I had some editing issues on the other PowerPoint. So I'm just starting on here, and then I'm going to quickly skip ahead to where we were. I wanted to make sure I talked about psychotropic medication just for a second in our country. I have some interesting data from The Body Keeps the Score, which is a book by Bessel van der Kolk that talks about the brain and trauma. And I'm going to use some of that in the next chapter. But obviously, in previous years, patients were kept in asylums. But then when antipsychotic drugs, which we'll talk about in the antipsychotic category in just a minute, were invented, that greatly reduced the number of people living in asylums. And so with that, I want you to recognize that antipsychotics are one of the top sellers in the United States. Look at how much we spend on Abilify, which is an antipsychotic. And there's a huge disparity with prescribing to people in poverty, marginalized populations. And 500,000 children in the U.S. take antipsychotic drugs. Do you think that many children are psychotic? First of all, when can you diagnose schizophrenia? And what is going on here? Food for thought, something to consider, and perhaps us discuss when we meet again in our class. So back to our other PowerPoint, which is here. Make sure you understand just the different routes of administration for drugs. You'll need to know this because you have clients who are prescribed different medications or have had prior narcotic use and need to know what these terms are. Then we have the pharmacokinetic process. Pharmacokinetic, and this is the process for which drugs are absorbed into the system. You see the absorption of the drug in whatever form, we just saw the previous slide, the distribution of that drug, and then the excretion of that drug. This is just for you to understand that process. You probably already do, because most of us understand how this works, but this is just a review. And then we're going to go into how these drugs, the different categories of drugs and what you need to know. You definitely need to understand antidepressants. There are a series of inventions, creations of antidepressants. So we went through the first generation, which were monoamine oxidase inhibitors. And they weren't great because they had a ton of side effects. And what they did was inhibit the enzyme that breaks down the neurotransmitters. Remember from the other PowerPoint and talking about how that works. And then tricyclic antidepressants were developed to replace MAOIs, and they work by inhibiting the reuptake of these three neurotransmitters: serotonin, norepinephrine, and to a lesser degree, dopamine. They affect many different neurotransmitters and can also cause many side effects. An example given of that one, you're not going to see an MAOI prescribed, but Elavil is definitely prescribed more often than not. And so if you will have a client come in and say they're taking Elavil, you need to get a PDR. You need to be able to understand the brand name and the actual drug name. And you need to understand the main ones and how they work. And then we have the second generation SSRIs. And what these are more common SSRIs that you hear about. These were developed in the 1980s. And then newer ones come out pretty regularly that even are better. The SSRIs, they block that reabsorption of the serotonin in the synapse. So more of the chemical can be taken out by those neighbors, the neighboring nerve cells. They do not have many side effects, and your clients have to stay on them for a good amount of time. I say 4 weeks, we can start to really see a difference and the side effects subside. Please make sure you memorize all the names in your book of the drugs. So that will be fluoxetine is Prozac. Sertraline is Zoloft. I need you to know escitalopram is Lexapro. I want you to know all of those. Citalopram is Celexa. This is on page 291 under second gen antidepressants. Please make sure you know all of those, because when your clients come in, they'll say, I'm taking Fluvoxif something something. When they're doing a generic or something, it's not going to say Lexapro or Luvox or Zoloft. And you're going to look at them like, huh? So if you know those names, then you're going to have a lot more level of professionalism when those clients come in your office, because you're going to understand what they're talking about. Then we have the more recent third generation. These are atypical. They're not SSRI. They could be SNRI or SSRI. They're different than the SSRI. Sorry, misspoke there. So these are SNRI, selective norepinephrine reuptake inhibitors. And what they do is work on the reuptake process and increase the amount of the integrated chemical in the brain, like norepinephrine. Popular ones are these names here. Please know them, and please know their actual name in your textbook. Wellbutrin inhibits norepinephrine and dopamine and has fewer side effects, and often that is the right medication for your client. When something is not working for your client after they have been on it for about 6 or 7 weeks, and granted, if they're on the drug for 3 weeks and the side effects are horrible, you're monitoring them. Their physician, their psychiatrist is not going to see them probably for 4 to 6 to 8 weeks. So you are the one that's evaluating them. And if they're coming in and they're having their depression is worse, their anxiety is worse, they are not sleeping, not eating, there's things we can do, like take the drug at night before they go to bed, try different times a day, things like that, as long as the doctor says that's okay. And trying to figure out what works for them. Perhaps they have too much, perhaps they're on the wrong drug. You can have a very difficult time if you're prescribed the wrong drug. So sometimes you are the one evaluating and you may go, gosh, you know what? You're on an SSRI. I'm wondering if you need an SNRI. Perhaps you go back to the doctor and tell them and see if we should try something like Cymbalta. And then you can evaluate that. It takes an average of 4 tries to get the right drug match with your client. They can do genetic testing if you can find someone who can do that for you. We don't have a ton of options in LaGrange, but ideally they could get matched for the best genetic match for them. Then we have anxiolytics. Very, very powerful, very important for your clients. Clients are often scared. The ones who are scared to take anxiety drugs that are narcotics are the ones who are definitely not going to become an addict. I say that in joke, but you really do have this at your disposal. So sometimes when people are going through a horrific event, especially in the pandemic, there were tons of divorces that I was counseling a lot of people who were going through really difficult, very difficult divorces. And, had been married for years and years and years and had discovered things in the midst of the pandemic. And so, and we're going through a horrible divorce. And I have some relationships with physicians in town. And I started joking, it was the Doctorville special drug combo. And it was an SSRI or SNRI and a benzodiazepine low dose of Xanax or Ativan, like 1 microgram or 2 micrograms. So the clients are often panicking because I'm suggesting it, and I'm suggesting it so they can sleep and so they can function. And that is actually what those drugs are for. Short-term stressful life events and getting you through a horrific situation. It's going to calm your brain down and help you get through. And like I said, I would not ever recommend a benzodiazepine for someone who is an addict or has a propensity for addiction. If I have a client who is in recovery or on drugs, there are non-narcotic anxiolytics like buspirone that we can use and a histamine. And so these are different anti-anxiety drugs that are not a narcotic. Also of note with anxiolytics is the fact that there are antidepressants that work on anxiety. And those would be Prozac, Zoloft, Paxil, Lexapro, and Celexa. It takes a little bit for them to start working, but they can often work just as well. And there's no dependence. They're not narcotic, so you don't have to worry about coming off of the drugs. And we talked about antipsychotics already. Antipsychotics, you'll see clients come in and you'll see the med and you'll go, oh gosh, I wonder why they prescribed this. But a lot of times it's for mania from bipolar, severe anxiety, depression, severe mental illness. It's not just used for schizophrenia. Often, sometimes I think these are used just because doctors don't know what to do, and they don't look at the brain, and they don't have the time with the patient. So they just give them, and it's serious, so they just give them something that will get them in check quickly, with which these drugs are strong. They were first developed in the 50s, and you saw my Bessel van der Kolk slide before talking about that changing the asylums. And I have my own opinions about that. I feel we need asylums back. Asylum's a bad word. We need intensive hospitalization back for a longer period than 7 to 10 days. So we could actually find out and treat what's happening with people and the trauma that they've experienced. And then we probably would not have such a high prescription rate for antipsychotics. So you may have heard the Thorazine shuffle that's a term, Haldol-Thorazine. These are those older antipsychotic drugs. Every once in a while, somebody still prescribe those. So just FYI, you may be very confused at times, but in the mental health hospital, I often think we should go down to West Georgia to the hospital, West Central, and let you guys go and check that out. I got called in a case down there. It was a strange situation, but I actually went down to work with this individual, and he was so drugged. I went down to Columbus. He couldn't do EMDR. They wanted me to do EMDR with him, but he was so out of it. Like, it's so drugged. There's no way he could have been compliant with EMDR. And the place was like you see in the movies. Anyway, we should probably take a trip down there. Okay. So then we have, in the 1970s, we have the second gen atypical antipsychotics, which are more common, and they have a lot fewer side effects. You will see many clients who come in with these prescriptions: Abilify, Zyprexa, Seroquel, I don't know, Depakote's in here, Risperdal, Geodon, Latuda. You see that on TV. Latuda, it's a little happy, like, bubble commercial, I think. Some of these others you don't hear about as much, but just know them all. It's page 293 in your textbook. But you will have a large number of clients who come in and on their intake paperwork, these are the meds, and you think, gosh, I wonder why they're on Abilify. And sometimes severe depression, like I said, they will prescribe, doctors will prescribe. So it's kind of your job to, while you're not a physician, but it's your job to evaluate and make recommendations when they get back to their physician or their psychiatrist, saying, hey, we're doing this work on these things, and I'm thinking perhaps this client could use a switch. Maybe they're having horrible side effects, and it could be what's keeping them from getting better, quite frankly. You can look in the online PDR here or buy a PDR for your office and put the drug in here and pull it up. And we have Abilify here. Okay, it's a partial dopamine receptor agonist antipsychotic. It's got big box warnings here. Common brand names for you, how it's supplied, everything you need to know about the drug. So if your client comes in and you go, gosh, I can't remember what Dr. Bill taught us, I don't remember what Abilify was, you just go put it in and find out what's going on. As a neurofeedback provider, my clients can overdose on their meds once we start brain training. And I don't mean overdose like die. Overdose means symptomology. So side effects would start to come out. And that means we have to titrate down on meds. So I think that may seem scary for some of you to think about monitoring that kind of stuff. But as a neurofeedback clinician, that's part of our job. And so when their brain chemistry starts to work differently and their hearts and their brains start to reach homeostasis, when that drug is doing something, the same thing, and you get to the side effects. So what I have to do is pull this up. Even WebMD, sometimes I can put, because the clients will come and go, gosh, I'm feeling really agitated. Well, it's a side effect of the drug they're on. So I'll say, okay, go to your physician, go to your neurologist, talk with them and see if they're okay. Because we can't make that decision. Always have a physician make the decision, but I make a recommendation and let them know what we're doing and see how they feel about you coming down, and let's see how you do. We keep draining the brain down. So we've got several people off almost all their meds. Some people need to stay on a low dose of something. A low dose probably is not going to make you have those side effects. The mood stabilizers, you're going to see big time. You'll see, this is Depakote, sorry. Sometimes, a lot of times, a client who has schizophrenia often has also a Depakote prescription. So they're mood stabilizers, and they help people with bipolar. One of the ones that is not, and they use anticonvulsants as mood stabilizers for rapid cycling bipolar. So that's the Depakote, Lamictal, and Tegretol. But you see that sometimes, you'll see those drugs for people who do not have rapid cycling bipolar, severe depression, hallucinations, delusions. I'm trying to think what else. Just overall severe mental health issues. I added this new stabilizer, Vraylar. I am so impressed with Vraylar. I have 2 severe bipolar patients, and one of them has been mentally ill her entire life. They are both only on Vraylar, and I'm doing EMDR with them while on Vraylar, and they're just an amazing story. Neither one of them have ever been this stable in their entire life. One, we're starting to reduce Vraylar. Be interesting to see what happens here. I have my own biased views of mental health and diagnoses. But this is, and I wrote this, I pulled this off the internet here. And this is, Vraylar is cariprazine. I may not be saying that correctly, and is a new dopamine receptor ligand developed for schizophrenia and bipolar. And what this one does is it displays a higher affinity at D3, so dopamine receptors, and a similar affinity at D2 receptors and 5-HT2B. And we need to look that up. I'm not sure what that is. Let's figure out what that is. Okay, so Wikipedia is your friend in these situations. If you wonder how I'm doing this, I can pause. I can pause myself and come back on really quickly, so you don't have to see me messing around trying to figure out anything. But look, this is, and I didn't know what this was. So this is hydroxytryptamine receptor, 2B5HT. I do not have a genetics degree, but it is a serotonin receptor B. Okay, and so this new drug is working on this. So how interesting that we can get that precise. I think we'll see a lot of movement in our field with drugs and neurofeedback, transcranial stimulation, all the things that we're working with the brain, and being able to really target and be very particular with our clients and matching what they need versus just blanketing it with some kind of antipsychotic. Alrighty. Now, believe it or not, the clients are going to come in on all sorts of drugs, including these drugs. And clients for which you think, how did you get a prescription for Adderall and Xanax and an antidepressant, and you're taking all of it? So they do, and it's coming from doctors. Again, this is often a more privileged drug, I would say. I see more privileged clients coming in having a script for Adderall and kind of a script for whatever they need. So what the problem is with this is Adderall is just amphetamine, basically. So I kind of like bluntly say, I mean, you're basically taking meth. It's fine. But all that to say, these meds work and they're okay. It's just that a lot of times people come in and they're taking too much of it, or they didn't need it in the first place. So if you don't need it in the first place, it's problematic. But there's other options for you that are non-stimulant down at the bottom. And one of the ones, and Lexapro also can be used for focus, but Wellbutrin is a good one. That is, you remember, back in atypical antidepressant, back in that slide. So also, if you have a client who's having focus issues and you're making a referral or following them, we can talk through these options. Perhaps there's another option, a non-stimulant option to try first before moving to an actual narcotic that has strong narcotic in it. You see the different kinds. Some are short acting, some are long acting. Often your clients are needing something to sleep. Children and teens, they take an upper during the day and a downer at night. And biases against about how that is affecting children and their brains. I wish I had actually done a formal study, but my drug court clients, I would say about 60% of them, especially the males, primarily were prescribed Ritalin as children. And they had trauma to boot, but it probably most of the time was trauma. And there's plenty of research to back up that statement. It was the cover of our Counseling Today magazine a couple years ago. I've got that somewhere. But, adverse childhood experiences cause symptomology that mimics ADHD. So, is it ADHD or is it trauma or is it no food or is it no lights? I mean, there's a lot of variables here. If you read through the diagnostic criteria for ADHD, it could be anything. They could be depressed, highly anxious. So, I'm a huge believer. I have ADHD, so I'm a huge believer in the diagnosis. But it is way overdiagnosed for problematic children, and it is a problem. But also, I'm not saying that it's not important and you shouldn't have a diagnosis and shouldn't get treatment, because if you need to have the medicine, it works. So I'm not anti that at all, but I see clients come in with, 50, 60, 70 milligrams of Adderall. I mean, it's way above the dosage that they should be taking, and it's making them literally crazy because they're basically, methed out all day and then taking downers to sleep. So that's just really wreaking havoc on their systems. You've got to be able to talk medication with clients. If you have gotten anything out of this talk, it should be that. And that's table 11.5. I want you to be familiar with that. Go over and over and over and over and over it. I'm not going to do a quiz on it, but those are the drugs that you're going to hear about and you need to know about. I will give you also Ambien. Watch out if your clients have that. It causes sleepwalking, and I've had several clients get DUIs on it because they sleepwalk and drink and go out in the car and drive around. They have no idea what's going on. But you've got to be able to talk with your clients. I've been emphasizing this throughout this entire lecture, but making sure that you are talking with them. What side effects are they experiencing? You pull up the PDR, pull up WebMD, talk about compliance, educate. You have to use PsychoEd. Your other clinicians are not going to do it. They don't have time. They have to take it every day. They need to take it at the same time. If they miss one, it's going to cause problems. They can't just quit taking most of these medications. They will have horrible side effects. And then I'll reduce the stigma. Lots of the large percentage of people that take medicine is here for a time such as this. I talk about that a lot. Like, we have gone, thank goodness we have medicine. I think whatever universe or however you want, a spiritual entity, however you want to think about it, 2020 and 2021, I mean, I don't know what would have happened if we didn't have medicine. It saved a lot of lives, honestly, and thank God for it. So, make your clients feel normal about taking something. There's no shame in taking medicine. It doesn't mean they have to take it for the rest of their lives. It can be used for short term, or they may have to take it for the rest of their life. And there's nothing wrong with that. If it is going to help them have a better quality of life, better relationships, and it's not going to cause any adverse effects, I mean, there's no problem with it. You have to be able to talk with other providers. I've also emphasized this throughout the lecture. You have to respect other providers. And like I said, and your text on page 301 is going to say exactly what I've been talking about. You are the only one who really knows what's going on because you're spending 50 minutes with them every week. And you know how they feel. You know what's going on. You know if they're taking their meds, if they're not taking their meds. And then they check back in for 5 or 10 minutes with the doctor. And, oh yeah, I'm fine. So you have to advocate and talk with other physicians. I have relationships with physicians in town, and I can text or call and say, hey, so-and-so needs to get in, or we need an SSRI or an NRI. What do and they go with what I say, which is crazy. But I mean, they respect my opinion. They respect that if I say, I think they're on too much med, this is too high dose, can we try to come down with the neurofeedback and everything we do at the field group? They listen. And now they're the ones that make that decision, but they know that we have a lot of good data. So respect everyone, build those relationships.